The broadcast is now starting. All attendees are in listen-only mode.
Hello, welcome to today's Professional Development Workshop. I'm excited to be presenting to you today. My name is Donna Riedle. I am the Registered Nurse Consultant for IPMG. The workshop today is Specialized Dietary Support, providing person-centered nutritional support. So the purpose of today's training is to increase your awareness of the many specialized dietary needs among the disabled population, to clarify the importance of following physician-prescribed dietary orders, and to clarify the different types of dietary modifications. And also, we will be reviewing dietary risk plan needs and requirements. So today's PDW will give you an overall view of dietary planning. At the end of today's training, you'll be able to understand the components of having a specialized diet plan, understand the different types of dietary modifications, and you'll understand potential specific dietary requirements for individuals with Down syndrome, Cerebral Palsy, and Prader Willi Syndrome. We will review current dietary risk plans. You will be able to review your current dietary risk plans for quality and completeness. So you'll be able to take the information you learned today and bring it back to the individuals you serve and to support their dietary needs. So, what is a diet? Well, in today's world, diet is discussed by almost everyone on a daily basis. A discussion about diet comes in many settings, from fitness class to cocktail parties. To some, diet means weight loss eating plan. You know, what kind of diet are you on? Are you on a diet? This diet works for me. What does it work for you? But to others, it means what foods we consume or feed our loved ones on a regular basis. So for purposes of this discussion, the word diet will be defined as the food and drink that is consumed in terms of quality, composition, and effect on health. And a diet is individual nourishment. Well, the ultimate goal in nutritional intervention should be to optimize health, fitness, growth, and function of all individuals served, but it should also include how food affects not only a person's health, but mental well-being. Food or diet choices should consider love of the food, the satisfaction felt when consuming the food, and the overall enjoyment of the meal. And this is, shouldn't be dependent on what kind of modified diet plan is in place. Diet or food choices and consumption can play a huge role in the quality of life issues. And that's something to keep in mind as you're planning diets. When a person has an individualized diet plan, there are several factors that must be considered. The first of these factors is the person's health needs. The team needs to be aware of the individual's health needs. For example, do they have a nutritional deficiency, such as some type of inborn error of metabolism, where they need to follow a specific diet plan? They may have an acquired disease such as celiac or type 2 diabetes. It is important for the team to know, and most importantly understand, all diagnosed medical conditions to assure the individual is receiving the appropriate diet to support overall health. Secondly, safety needs must be considered. The team must discuss if there are any safety needs that need to be addressed around mealtime. If so, is the risk plan detailed enough to support these safety needs? Safety needs may include such things as the staff encouraging the individual to eat more slowly, or a detailed plan that describes positioning needs. Finally, individual choices must be considered. I believe that this is probably the most overlooked aspect of diet planning. As a team or provider, meal and diet planning may focus on health and safety as top priorities. So oftentimes the team does look at the safety of the meal. What is being fed and is it being fed safely? And this is important, but having foods available that the individual likes and enjoys can go a long way in promoting health. Take a moment and think about something that you just love to eat. It just makes you feel happy, satisfied, and warm all over. Mine, for example, is my grandmother's goulash. When I eat a bowl of this hearty stew, I feel warm, comforted, and actually love. I've eaten this dish since I was a child, and it makes me really happy. And so I believe most everyone has this type of experience around food, which brings us a lot to comfort foods. What are comfort foods in our world and our lives? So we have to keep in mind that food is not just about nourishment, it's about comfort and joy. Food makes us happy, it brings us together, and it keeps us healthy. So the other side of this is if we are given foods that we do not like because someone else was making the decision for us, would we eat it? And would we like it? And would our food time or meal time be enjoyable? So as a first step, I encourage all of you to support a healthy, safe, and enjoyable diet plan for all the individuals you serve. You know, at team meetings, why not ask about what their favorite meal is and make a note of it so that meal planning can be made around that. So how can we provide for a healthy, safe, and enjoyable diet? First, education of the staff that is providing support services. To reach this goal, we start with a person-centered plan. As the team begins to know the individual by asking questions, talking to friends and family, the team will begin to gain knowledge about the individual's wants and needs and what supports are required. Keep in mind, this is as much about what is needed as it is about what is wanted by the individual. Therefore, educate the staff on the individual. Secondly, educate the individual. Depending on the person's level of functioning, educate him or her on their specific dietary needs. As they age or their health conditions change, re-educate so they can understand how to make the best choices. This, of course, is unique for each individual. Always include the individual in the process. Help them feel a part of the team. Imagine if corn on the cob was one of your most ultimate favorite summertime foods. You had to have it. You loved it. But you were never able to eat it again because someone else was planning your meals. So, you know, why it's important to include the individuals so that they can have some enjoyment. One way to do this is grocery shopping with the individual. This is a very important step in empowering them to take control of their own diet and, in turn, their own health needs. This may feel like a cumbersome process at times. And I know, I've been there. I know it can be difficult, challenging, and even time-consuming. But it is an important first step in promoting life independence and health. Next, risk plan development for specific needs. Risk plans not only protect the individual, but they also protect staff and service providers. A well-written risk plan can go a long way in meeting an individual's health and safety needs. Include in the plan details that support the individual's specific likes and dislikes, such as corn on the cob. And then finally, risk plan training. A well-written plan is worthless without the training that goes along with it. It is important that everyone who supports the individual is trained on the risk plan and that it is followed as written. The staff should be encouraged to give feedback to the team if the plan is not working, so that the plan can be updated and modified, keeping in mind that the risk plan is a living document. They should be modified and changed as needed. It is important to remember that plans are important in order to provide consistency also. Another detail about the plan is that, for example, if a plan states, that the individual, the staff will provide a healthy, quote-unquote, diet, what's healthy to me and what's healthy to you could be very different things. That's why the plan must be clear and detail-oriented. I'll be discussing risk plans in more detail towards the end of this presentation, but that was just kind of a little tidbit about risk planning. There is so much to consider when planning an individual's dietary plan. For example, if they're having some motor issues, difficulty in chewing and swallowing, an evaluation by a speech-language therapist or other professional is needed. This is a starting point if there are safety concerns around food choices. Then there are specific dietary requirements that may be prescribed by a physician. This may include, but is not limited to, a diabetic diet, low-calorie diet, or a heart-healthy diet. Think about how these needs are being met for individuals you currently serve. Are they given options to what they can eat? Are they involved in the planning process? A suggestion came to me from a case manager about how specific dietary restrictions could be supported for an individual. For example, for those with dining restrictions, the provider could supply a list of options for meals. Then the individual can choose from that list. This way, there are healthy options, and the individual still can choose what they would like to eat. Also, if they want sweets, then they could help bake or create a delicious dessert that follows their dietary restrictions but still allows them the ability to have a sweet dessert. Another suggestion was that if the individual had a calorie restriction, there could maybe be a daily log that the provider has put into place where the staff can keep track of protein, fruit, vegetables, sweets, and what the individual has eaten throughout the day. And so this log would help keep staff on their toes to ensure a balanced, healthy meal. I think the more important thing about meal planning is to keep it creative and find a system and plan that works for the person, and so that therefore it's person-centered. Another option may be a nutritional consult. Unfortunately, this is not covered by waiver services, but is something that the team may want to discuss if a dietary consult is warranted in order to get the individual on track. A dietary consult may or may not be covered with Medicaid. This would have to be looked at an individual basis. Once again, safe mealtime practices must be followed and be supported by everyone in every setting. This is a really good thing to keep in mind as individuals go out into the community. So the meal planning must be shared with all staff and family members who will be with the individual during mealtime. This would include all community outings. Also, keep in mind, if the individual is going home with family for the weekend or holiday, all mealtime practices and safety precautions must be followed. And it must be confirmed that all family and staff understand mealtime requirements. And in this regard, I would suggest that the staff or the provider ask the family to reiterate what the safety meal planning requirements are, so that you really know they have a thorough understanding of what this individual will need. So, why are specialized diets necessary? Sometimes these are all kind of just variable reasons. They don't all apply to the same individual. But some reasons may be to maintain, restore, or correct nutritional status if they have some kind of nutritional deficiency or have been sick in the hospital, to balance calorie intake for weight gain or loss, to manage diabetes or other health conditions, or maybe to exclude foods due to allergies or food intolerance, and also to provide texture modifications due to problems with chewing and swallowing. And we're going to go into more detail specifically about texture modifications. So there's a high prevalence of dysphagia in persons with intellectual and developmental disabilities. It's estimated that 80 to 95% of all individuals with IDD are expected to have swallowing and feeding problems at some time in their lives. Individuals may need a modified diet for many reasons. Orders for modified diets must be written by a physician. It's not just some arbitrary, decision made by the team. It must be ordered by a physician. And modifications may be needed because of inadequate chewing, no teeth, or maybe dysphagia. Modified textures are easier to chew and manipulate, and they require less effort for the individual to consume the food. Now, I have done a lot of research, and unfortunately, and it's kind of interesting after all these years, but at this point in time, there's no universal language for describing a modified diet plan. And this could explain a lot of the confusion out there as to why people aren't quite sure what modified diet means for a particular individual. So because names of modified diets can vary across settings, I strongly suggest that the team always gets a specific description and documentation of exactly what the individual diet orders look like. Whether it's a physical description or pictures or whatnot, I really, really encourage lots of asking of questions. So I will describe modified diets as defined by the National Dysphagia Diet Association. And the way that I'm going to describe to you is using that description. You may see mechanical, you may see mechanical 1, 2, 3. You may see regular is pretty common and pureed. So I'm going to give you an idea, but once again, get a full description. So as you can see, there's diet level 1, which is pureed, 2 is mechanical altered, 3 is advanced, and then there's regular. So to start with, we'll discuss the pureed diet, or level 1. The food is a pureed consistency. The food is homogeneous, it's very cohesive and pudding-like. It requires very little chewing ability. This is for individuals who have severe difficulty chewing or swallowing. All foods pureed blended, and it's very smooth in texture, as you can see from the picture. And it's important when serving pureed foods and other foods that have modified texture to make it appealing, make it appetizing, serve it in a nice dish, just kind of make it look like the person, is making a mealtime an event, even if, pureed diet may not look all that appealing. But it is a very safe diet, obviously, for people who can't chew. Level 2, mechanical altered, has cohesive, moist, semi-solid foods, and requires some chewing. Not very much, but some. And it's for individuals who have limited chewing or swallowing mobility. And the swallowing mobility and chewing will be evaluated by a speech pathologist or another professional. And again, the diet will be ordered by a physician. Once again, the food should look palatable and have some variety of color, but this is a mechanical 2 diet. Level 3 is advanced dysphagia. This is soft foods that require more chewing ability. So this is for individuals who have mild chewing and swallowing deficits. They have increased difficulty tolerating certain types of meats, fresh fruit, and raw vegetables. There's some soft textured foods that do not require chewing, and that might be such thing as an egg, over easy egg. And sandwich meats are whole, and other tougher meat foods are chopped or ground. And you can see from the picture kind of an idea of what that diet looks like. And this is a really good idea, if you have someone on a modified diet, to have pictures available for the staff to be able to determine, what kind of food the individual is capable of eating safely. A regular diet, all food with no texture restrictions. Though sometimes they will have a peanut butter restriction, and because peanut butter can, as you know, kind of get clogged up and cause some choking issues. So peanut butter can be thinned with syrup, honey, or jelly. And you can see from the picture, normal diet, normal chewing, no issues whatsoever. So that is a regular diet, and that is a universal description, regular diet. So individuals, we're going to talk about fluid modification here, because oftentimes when individuals are on a texture modification, they're also on a fluid modification. And the number 1, individuals on a pureed diet modification will most often be on a liquid modification. So we need to thicken fluids, because thickened fluids help reduce the risk of liquid going into the windpipe or the trachea, because the trachea leads into the lungs. And if liquid gets into the lungs, it can cause pneumonia. And pneumonia then, of course, is lung infection. And lung infection can cause damage to the lungs. So that's why thickened liquids help the individual kind of handle that better, so they're not choking or aspirating. Thickened liquids move slower to give better control of the liquids in the mouth, so swallowing can be safer. And there's 2 types of thickeners, powder and gel, which I'll go into in a minute. So fluid modification, a thin diet, which is just regular. Every old, it's you and I have a regular thin liquid. No changes are necessary. Nectar-like as fluids that are thin enough to be sipped through a straw or from a cup, but thick enough to fall off a tipped spoon slowly, so like eggnog or buttermilk. So I encourage you, as we're going through these descriptions, to think about people that you support, people that you serve. What kind of diet modifications? Does this fit them? Has the description been clearly documented in their dietary plan so it can be thoroughly understood by the staff? Honey-like is thick fluids eaten with a spoon or sipped from a cup. Liquids are too thick to sip from a straw, such as thick yogurt, tomato sauce, or room temperature honey. And pudding-like, that sounds pretty obvious, spoon-thick. Pudding-like fluids that must be eaten with a spoon that hold their shape on the spoon. Does the staff really know what these descriptions are and how they look? And which brings me to this graphic. I mean, this graphic would be a great thing to have available in the home, something very similar to it, so that the staff has some kind of guidelines, or if someone's filling in for the day, they have some kind of guidelines. Some commercial thickeners that are available include Thicket, Thicken Easy, Thicken Up, and these can be added to hot or cold beverages. Those are more for the drinking type food source. Food thickeners can be used such as baby cereal, mashed potato flakes, graham crackers, vanilla wafers, okay, things like that, but cannot be added to beverages. It just obviously wouldn't work if you think about those food thickeners and how that wouldn't work. And using different thickeners, kind of keep in mind that this adds calories to the food. So if the individual has a calorie requirement, that this must be considered. And the best choice would be to choose one that's low calorie, obviously. So just a really good graphic to show you what thin liquids look like. All right, so that encompasses all the dietary modifications, the dietary texture, the liquid, the changing of the liquid. Now, what specific population possibly might need some of these dietary modifications? So this won't encompass everybody, but it'll encompass some. So I'm going to take a moment here to focus on specific dietary needs for individuals with specific disabilities, like I said, cerebral palsy, Down syndrome, and Prader-Willi. This in no way applies to all individuals with these disabilities, but it is to be used as a general guide of things to consider. I'm going to start with individuals who have cerebral palsy. There are some specific physical characteristics that could or may play into dietary needs that individuals with cerebral palsy may need to have in place. One thing to keep in mind is that individuals with cerebral palsy often present with short stature, which may be due to nutritional stunting in childhood, which is one big reason to consider nutritional status in all individuals so they get maximum growth and strength of their bodies. Good nutrition provides for optimum growth and improvement of overall health. People with cerebral palsy often have changes in their body due to scoliosis, spasticity, contractures, and limb differences can affect nutritional status and food safety. I mean, that's because things like scoliosis causes you not to be able to sit up straight, and oftentimes then the food doesn't go down straight. Spasticity causes movements and contractures that may affect overall muscle tone and cause some safety issues with eating and positioning issues. Oral motor skills may be affected due to neurological impairment and must be taken into consideration when talking about food consistency issues. All individuals with cerebral palsy should be screened for dysphagia. Individuals with cerebral palsy should have a dietary consultation to determine their own unique nutritional needs. And as they grow, as they get bigger, their nutritional needs and safety status can change, something to always keep in mind. Gastrointestinal issues are very prevalent in individuals with CP. The neurological impairment can affect their oral motor function as well as the mobility of the gastrointestinal system itself, especially their colon, and if their colon motility is decreased, this can lead to constipation. Whenever there are gastrointestinal issues such as diarrhea or constipation or stomach upset, the possibility of autoimmune disease should be considered. So this would include things such as celiac disease, food allergies, and esophagitis, which is an inflammation of the esophagus from having the food from the stomach kind of back up into the esophagus. Dysphagia evaluation should be completed on any individual with cerebral palsy who has had a history of feeding difficulty. Though keeping in mind that as people change, so can their feeding status. Some of the red flags that dysphagia may be present include recurrent respiratory infections. This could be due to possible aspiration or what's called silent aspiration, where it's not really obvious that they're aspirating stomach contents into their lungs. Or a hiatal hernia, which is when the stomach raises above the diaphragm and can cause stomach contents to come back up into the esophagus or the mouth. Or GERD, which is gastroesophageal reflux disease. And scoliosis, which is the curve of the spine, may cause the food consumed to get stuck or not move through the gastrointestinal system effectively. And also keep in mind that severe constipation is a sign that motility may be impaired and can also cause the stomach and gastrointestinal contents to kind of back up. And all this you can kind of see if you're not sitting up straight and you're unable to get that food to good gravity to kind of pull that food down through your body, you could have some of these issues. So something really, really important to keep in mind. Excuse me. It cannot be overstated that constipation is a big issue for individuals with cerebral palsy due to their neurological impairment and potential gastrointestinal motility problems. Decreased gastrointestinal motility, low muscle tone, medications, and decreased ambulation all contribute to problems with constipation and therefore dietary management. Dietary modifications to combat this problem may include increasing fluid intake and increasing fiber intake. But be sure to always increase the fluid intake before the fiber due to potential of causing constipation with increasing fiber too quickly. If individuals' food choices do not support increased fiber foods, fiber supplements may be helpful. This increase in fluid and fiber are not always effective, so medical intervention and follow-up may be necessary. A bowel tracking program may be necessary for these individuals. Dysmobility or dysfunction or decreased gastrointestinal mobility can contribute to the feeding safety issues. Dysmobility is a condition in which muscles of the digestive system become impaired, and changes in the speed, the strength, and the coordination in the digestive organs occur. So in the normal small intestine, liquefied foods and secretions, including digestive enzymes, are pushed onward through the system by waves of muscular contraction. Dysmobility can present as GERD, gastroesophageal reflux disease, delayed stomach emptying, and dumping syndrome, which can cause nausea and vomiting. So if the individual is having a lot of nausea and vomiting, this could be dumping syndrome. The diagnosis of these problems will lead to diet modifications and can make feeding more pleasurable and better tolerated, which will promote weight gain. So it's important to kind of be aware of overall health, wellness, and what's going on around feeding time for quality of life issues. Spinal abnormalities such as scoliosis can result in nutritional issues such as diminished gastric capacity, it makes the stomach smaller, the small intestine smaller, GERD, and difficulty in positioning for feedings, and changes in motility that can cause early satiety, nausea, and vomiting. So they get more full, they feel nauseous, they stop eating, and their nutritional status diminishes. These side effects can cause decreased food intake and have the potential to cause malnutrition. People with cerebral palsy have increased energy requirements due to spasticity and other motor dysfunction. So here you have an increased energy requirement and maybe decreased food, so therefore increasing malnutrition. So this increased energy requirement demand increases calorie intake to support overall. Increased calorie intake is necessary to support overall health and nutrition. Therefore, it is imperative that all issues surrounding the diet are properly addressed in order to promote a nutritious and safe and enjoyable feeding experience for people with cerebral palsy, improving quality of life. So I'm going to move on to Down syndrome. Individuals with Down syndrome may present unique dietary challenges, and these challenges may change across their lifespan. Oral motor skills are variable and change from infancy to adulthood. Decreased muscle tone is a hallmark among individuals with Down syndrome. The decreased muscle tone can cause issues with feeding and metabolism. Some common oral motor skill challenges include tongue coordination, sensitive gag reflex, delayed eruption of teeth, and difficulty with lip closure. These common problems can cause problems with coordination and chewing and swallowing food. These issues may cause a decrease in food intake and then have potential to lead to malnutrition. Constipation also can be a problem with individuals with Down syndrome. Constipation due to low fluid or fiber intake, poor muscle tone, decreased activity, hypothyroidism, excuse me, and Hirschsprung's disease, which is a disease of the large intestine, which can be present in Down syndrome. This is a missing of nerve cells in the colon. So the recommendation for diet is that the diet should be high in fiber and increased fluids and whole grains, because fiber and fluids helps reduce constipation. Fiber substitution is okay. Probiotics are a great source to help improve gastrointestinal health, and stool softeners may be needed. As you know, obesity is common in people with Down syndrome due to their low muscle tone and low calorie requirements. Individuals tend to be more sedentary, and there is a high and there's also a very high incidence of feeding problems among individuals with Down syndrome. And according to the research and documentation, that individuals with Down syndrome can be very picky eaters. So something to consider when making food choices, that you're making some choices that they like. Adolescents and adults with Down syndrome tend to be shorter than their peers and have a lower resting metabolic rate. And according to research, it's 10 to 15% in the general population, so their metabolic rate is 10 to 15% slower, so their calorie requirements would be less. So they, the dietary-wise, their calorie intake should be monitored. So that's a specific dietary issue for Down syndrome. Other medical conditions that can affect dietary that you may not have thought of include congenital heart disease. This occurs in 40 to 50% of individuals with Down syndrome. Congenital heart disease can cause feelings of being more tired and just not feeling hungry. Also, GERD, or gastroesophageal reflux, due to low muscle tone, can cause pain, and which then could lead to picky eating, because if you have ever had severe heartburn, you just don't feel like eating. Hypothyroidism occurs more frequently in people with Down syndrome than the general population. This causes a slower metabolism and increased weight gain. And celiac disease, which is an autoimmune disease to gluten, is very common among individuals with Down syndrome. This decreases their food choices, and if the diet's not followed, they can have gastrointestinal pain and issues, which will decrease their food intake. Once again, it's important to know the specific needs and wants of all individuals and tailor the dietary plan to be healthy, safe, and enjoyable. Diabetes is also more common with Down syndrome, so individuals you support may have a diabetic risk plan in place. The next disability I'll be talking about is Prader Willi. Individuals with Prader Willi Syndrome have a hypothalamic dysfunction, and this causes an excessive appetite, and which causes a need to control their food environment by controlling access to food and by doing such things as locking cupboards. People with Prader Willi Syndrome usually struggle with weight all their lives. They appear to use fewer calories each day, so eating normally, quote unquote, can cause them to gain weight extremely fast. So restricting food has the potential to cause deficiencies in micronutrients, so therefore it's preferred that dietary guidance should come into place and have a nutritionist kind of plan their meals, because of the fact that maybe they eat less, and so their vitamins, minerals, enzymes, all those things are decreased and causing decrease in overall health. Okay, so we're going to take the next step forward. So what are some barriers to healthy and safe dietary choices? So now that we've talked about some specific dietary needs for specific disabilities, let's take a bird's eye view of potential barriers for healthy and safe dietary choices for all individuals. These could apply to anyone, those with a disability and those without. I encourage you to keep a broad view of dietary needs, and as you go throughout your day, think about yourself, your family, and their own unique needs. Then, as you support individuals with disabilities, transfer your own personal view to their individual support. Whenever I'm supporting an individual within their personal needs, I always ask myself, is this what I'd like for my child, my brother, my mother? Then I kind of feel that I'm able to see more clearly what the individual needs are. Some specific barriers to healthy and safe dietary choices include physical disability. Can this person shop? Ask yourself, can this person shop for their food, prepare their food? How much support do they need? The second is choice. Are they able to choose what they want to eat, verbally or otherwise? For individuals who are nonverbal, who are unable to state their likes and dislikes, I would suggest a food log of sorts, where the staff can determine if the individual appears to have a particular taste or distaste for a specific food. So if there is a consistent distaste, change out the menu, make it more interesting, find something they like. The third barrier is, does the individual have a reduced ability to eat regularly? Is he or she sick often, tired from heart disease, in pain? If so, address the needs and reevaluate meal times. Meal does not necessarily have to be at 9, 12, 3, and 6. So does this individual lack time, energy, and ability to prepare their own food? What can the team do to put in place to address these issues, such as meal preparation, planning ahead, having pre-made or frozen options? How about medications? Are there any meds that they may cause nausea, sleepiness, and lack of hunger? If so, can meals be planned at a time during the day when these symptoms are decreased? So be flexible, be individualized. And number 6, does this individual have difficulty chewing and swallowing? Do they need a modified texture diet or liquid modifications, as was described earlier? A modified diet has potential in decreasing nutritional status due to decreased consumption, dislike, and texture. So therefore, it may be important to start weekly weights of individuals when the new diet modification has been put into place. All things to consider about what barriers might be out there. So how can we keep all individuals that we support healthy and safe during mealtime? You need to know the recommended liquid consistencies needed, talk with the physician or speech-language pathologist, and develop a plan. If a thickener is needed for someone that is unsafe with food or thin liquids, determine what type of thickener is to be used. Discuss with the physician to make sure there are no restrictions or allergies to the type of thickener being used. Remember, beverages, thin soups, and even liquid medications, one of the things that are often overlooked, may need to be modified. Ensure that the food or liquid, the medication stays proper consistency. You don't want it too thick, you don't want it too thin, kind of has to be monitored all the time. As I said before, monitoring weights when starting thickened liquids to see if the addition of the thickener has an effect on weight. If weight gain is to be avoided, or if there is a medical condition that may be negatively impacted, such as diabetes, try a thickener that has fewer calories. And always be very positive and encourage the person who's receiving the thickened food or liquid, because oftentimes at first it's not very palatable. Things to consider with a modified diet. Diet modification is that the risk for malnutrition and dehydration increases when the diet is altered. So this is something that should really be kept in mind, and maybe even develop a risk plan for dehydration if the diet modification is new. And that's because the food may not be as appetizing, it passes through the body faster, it absorbs less nutrients, and it is more difficult for the individual to get enough liquids when it's thickened. Once again, a nutritional status evaluation can be very, very helpful, especially if there's a risk of dysphagia. And a formal nutritional assessment should be completed by a dietitian. Preventative measures, some general mealtime factors. Keeping in mind that individuals who are sick or have heart disease or have specific physical conditions may not be able to tolerate 3 large meals, so 5 small meals during the day may be appropriate, something to discuss as a team. Repositioning for individuals may be needed often. And so don't think that just because they're in this one position in the beginning of the meal that that's going to be okay, because they slide down and move around and slip around. Individuals may fatigue through the meal and have more trouble swallowing safely as the meal goes on, and the strategies may change over time. These are just some tidbits to keep things kind of in perspective on what things you need to be looking at, some preventative measures. These are not specific to any special group of people, but just overall ideas. Make sure that, I'm going to show you a picture in a minute of a risk plan, but make sure the person is properly elevated, aligned, and supported, and that the head is midline. Think about how you ideally are sitting and eating at a table with a chair, and what your position of your body is, and that's how that person should look. They may need adaptive tools, such as divided plate, small bowl spoon, measuring cups, adaptive items to help keep them in the right position, and then, of course, environmental diet modifications. It is important to have a very clear dining plan in place for all staff, as well as any substitute staff that may fill in for permanent staff. This is a good example of a dining plan, so I'm going to go ahead and break this down in the next couple of slides. Just keep in mind that risk plans are written for direct support professional staff and can be thought of as a quick action care plan that provides integrated, interdisciplinary approach to keeping people as safe and healthy as possible. The purpose of a risk plan is to give a set of clear, concise directions that guide the direct care staff in recognizing and acting on important health care behavior risks. A risk plan will spell out the problem. So I guess number one I want you to take from this is clear, concise, and easy to follow. So this is a basic risk plan, the start of one. I've kind of tried to break it up a little bit for you. I really like this because it gives an example. It says exactly for the beginning, the individual refuses to eat, blah, 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 the grandmother says. These are really good guidelines for people to follow. This is great because it's food texture, fluid consistency, calorie modifications, all of it spelled out right there on the risk plan. Very clear, very concise, very important. The dietary risk plan, as it continues downward, you've seen from the very first slide I show you, there's actually pictures available. I think it's wonderful attached with this day and age how easy it is to get pictures. Attach pictures of the proper positioning, the kind of hand devices that are used. Really describe in detail what this individual needs for their specific needs. So no matter who is supporting the individual, they can see what's out there and what's needed for him or her. This is some interventions for a dining plan for dysphagia. I just, would suggest that it's very, very specific. So individual eats quickly and takes bites that are too large. So mechanical one diet is recommended. No fresh fruit except bananas. No canned citrus. Food should be cut up in 1/2 inch pieces. I often see food will be bite-sized. What's bite-sized to me and what's bite-sized to you might be two different things. So 1/2 inch pieces. Maybe even have a picture of food cut up into 1/2 inch size pieces. And staff to remain with the individual at all times. Signs of choking, what to do if the individual's choking. Very specific risk plan interventions that give a step-by-step. The staff does A, B, and C. This is really, really important about risk plans. This is another example. I know the clarity isn't all that good, but this is for a Puree diet. It kind of gives the definition of the Puree diet, so whoever's looking at will be able to see that. And it gives the appearance to smooth like pudding. And then it goes through and shows beverages. It says fruits, what's allowed, what's not, what to avoid. Meal, what's allowed, what to avoid. It's a great example of how you can have safe, healthy eating. And on this kind of a plan, it's great to have the individual's likes and dislikes included also. They will spit out at you every banana you try to give them. No bananas. Those kinds of things. So clarity is the most important thing about having a risk plan, and not to have leave anything up to interpretation. So these are just a few examples I have. So not clear, meat will be cut up into bite-sized pieces. Clear, meat will be cut into 1/2 inch pieces. All liquids will be thickened. Okay, what does that mean? All liquids will be thickened with thicket to a honey-thick consistency, including medications. That's really, really important. Not clear. Limit fluids during meals. That I see a lot. Limit fluids. What the heck does that mean? It means individual may only have 4 ounces of fluid during the meal. So when you're looking at your risk plan, go back and look at the ones that you have in place. How clear is it? Can anybody who walks in off the street read that plan and know what to do? Okay? And of course, when you have that super clear risk plan, education and training is super important. Training should be competency-based. And competency-based training can be divided into 2 categories. General or foundational competency-based training, and the second being client-specific competency-based training. I think that's kind of self-explanatory. The residential provider gives a general overall training, and then you go into the home and they have client-specific. And I strongly encourage there to be some kind of a playback. The staff is actually demonstrating how they're going to mix up and cut the food, things like that. So all staff should be provided with client-specific competency-based training that would include dysphagia training, mealtime planning, oral care, and medication administration, because anytime you have oral care, you're talking about similar issues as dietary planning and safety. And also positions for dressing, bathing, and personal care. Most importantly, again, training must be verified. I really strongly encourage that. If an individual has a specialized diet, I'm just going to kind of step forward here a minute to specialized diet planning. Specialized diet ordered by a physician, it's imperative that the diet plan in place that support staff is aware of what the diet plan looks like. It cannot be assumed that all staff knows, for example, what a heart-healthy diet would look like. Some specialized diets include diabetic, heart health, and obesity. Though freedom of choice does come into effect when planning a diet for an individual, it is important to give guidance and education as to why the diet is important and necessary. So always continuing to educate the individual and helping them even, like I said, shop, plan, all their meals. So here is, I'm just going to give you some tidbits on those 3 specific specialized diet plans. As far as interventions, this would be included in the risk plan. I have highlighted in red those that are specific diet related. The others are, the ones in black are the diabetes related. So as a diabetic risk plan, follow prescribed dietary plan, see attached plan. I would love to see, you know, the diet plan for a diabetic right there instead of, well, don't eat so much sugar, or eat one less dessert, or not allowed to have soda. Something very, very specific. Follow order as ordered by physician, and monitoring food intake. Staff will reinforce the importance of diabetic management with the individual. The staff isn't just sitting there just kind of doling out the food. They're actually helping the individual understand why they're eating that food. Heart disease risk plan, once again, the ones in red are the actual dietary interventions. You know, instead of saying eat a heart-healthy diet, and I do see that a lot, you know, the individual should be on a heart-healthy diet. What does that mean? It means 3 vegetables and 2 fruits a day, lean protein, fish, chicken, and turkey, high fiber, low fat, all these things here, portion sizes, things like that. And I even love, staff is to teach portion sizes using portion size guide from the WebMD that's posted on the refrigerator. Being overweight is a significant problem in persons with MR. Given this data, it is not clear whether the prevalence of overweight and obesity is different from the general population, but if an obesity risk plan is warranted, and if they have an obesity diagnosis, then one is warranted. This is a good example of some possible interventions. So kind of just take a look here, you know, what are the calorie requirements? Who's documenting the calorie requirements? What kind of food requirements should there be? Allowing personal choice and options, but giving guidelines. And this being in the risk plan helps the staff understand what is an obesity risk plan, you know. And, you know, if they do, you know, some people just have to have a little bit of few potato chips, well, then measure it out, you know. Well, here are your half a cup or 1 cup of potato chips, you know, for the day or for the week or whatever. Very specific, you know, easy to follow. So, you know, what's healthy eating? We talked a lot about quality, you know, texture, liquid, you know, different disabilities, different conditions, medical conditions. So, you know, when discussing meal planning, you know, once again, I think having conversation during the team meeting that includes what the individual is eating, what is a typical diet, discuss healthy eating, offer some type of chart or picture such as the one here, so that you can show the individual what a healthy diet looks like. Show them how to make healthy choices. This is a balanced diet. I found this on the internet. There are lots of different models out there, but this one is really visual. I would encourage, if you're having dietary issues in a household of individuals that, you know, are making their own food choices, this is a great example. Does your plate look like this? Have this on the refrigerator. Have this laminated and on the table as they learn how to make healthier food choices. And what that looks like, and what that really looks like. So this is the lunch and dinner menu, and then this is the breakfast menu, you know, a little bit leaner, you know, more fruit, got your protein, got your cereals, things like that.